Understanding inguinal hernia's symptoms and diagnosis. Inguinal hernias are a common condition that affects millions of people worldwide. They occur when a portion of the intestine or abdominal fat pushes through a weak spot in the lower abdominal wall. This creates a bulge in the groin area that can be painful and uncomfortable. Recognizing the symptoms of an inguinal hernia is crucial for early diagnosis and treatment. The most common symptom of an inguinal hernia is a visible bulge in the groin area. This bulge may appear suddenly or develop gradually over time. Many patients report feeling a heaviness or pressure in the groin, especially when standing or coughing. Pain or discomfort in the affected area is another telltale sign. Some people may experience a burning or aching sensation that worsens with physical activity. Diagnosing an inguinal hernia typically involves a physical examination by a healthcare professional. The doctor will ask the patient to stand and cough, which can make the hernia more prominent. In some cases, additional imaging tests like ultrasounds or CT scans may be necessary to confirm the diagnosis or assess the extent of the hernia. It's important to seek medical attention if you suspect you have an inguinal hernia, as complications can arise if left untreated. Once diagnosed, the next step is to determine the best course of treatment. While some small asymptomatic hernias may be managed with watchful waiting, many cases require surgical intervention. Laparoscopic inguinal hernia repair has become increasingly popular due to its minimally invasive nature and faster recovery times. In the following sections, we'll explore this procedure in detail, from preoperative preparation to postoperative care. Preoperative preparation, setting the stage for success. Proper preoperative preparation is crucial for the success of any surgical procedure, and laparoscopic inguinal hernia repair is no exception. This phase sets the stage for a smooth operation and helps minimize potential complications. As a surgeon, I always emphasize the importance of thorough preparation to my patients and surgical team. The preoperative process begins with a comprehensive medical evaluation. This includes a detailed medical history, physical examination, and necessary laboratory tests. We need to assess the patient's overall health status and identify any potential risk factors. Common tests include blood work, electrocardiogram, ECG, and chest X-rays. These help us ensure that the patient is fit for surgery and anesthesia. Next, we focus on patient education. It's crucial that patients understand the procedure, its risks and benefits. I take the time to explain the surgical technique, expected outcomes, and potential complications. This helps alleviate anxiety and allows patients to make informed decisions about their care. We also discuss post-operative care and recovery expectations, empowering patients to take an active role in their healing process. Preoperative instructions are another critical component of preparation. Patients are typically advised to fast for at least 8 hours before surgery to reduce the risk of aspiration during anesthesia. We may also instruct patients to stop certain medications, such as blood thinners, a few days before the procedure. Smoking cessation is strongly encouraged, as it can significantly improve wound healing and reduce the risk of respiratory complications. On the day of surgery, patients should shower with an antimicrobial soap to reduce the risk of surgical site infections. Patient positioning and anesthesia, getting ready for surgery. As we move into the operating room, proper patient positioning and anesthesia administration are crucial first steps in laparoscopic inguinal hernia repair. These elements set the foundation for a successful procedure and contribute significantly to patient safety and comfort. Let's dive into the details of this important preparatory phase. The patient is typically positioned supine, lying on their back on the operating table. We often use a slight Trendelenburg position, where the head is lowered slightly below the level of the feet. This positioning helps shift the abdominal contents away from the surgical site, providing better visibility and access to the inguinal region. It's important to ensure that all pressure points are padded to prevent nerve injuries or skin breakdown during the procedure. Anesthesia is a critical component of the surgical process. For laparoscopic inguinal hernia repair, general anesthesia is usually preferred. This ensures that the patient is completely unconscious and immobile throughout the procedure. The anesthesiologist carefully monitors the patient's vital signs, including heart rate, blood pressure, oxygen saturation and depth of anesthesia. They make adjustments as needed to maintain patient safety and comfort. Once the patient is properly positioned and anesthetized, we prepare the surgical site. The abdomen is cleaned with an antiseptic solution to reduce the risk of infection. Sterile drapes are placed around the surgical area to maintain a clean field. At this point, the surgical team performs a timeout to verify the patient's identity, the procedure to be performed, and the site of surgery. This crucial step helps prevent errors and ensures everyone is on the same page before we begin the actual procedure. Creating the pneumoperitoneum, inflating the abdomen. Creating the pneumoperitoneum is a critical step in laparoscopic inguinal hernia repair. This process involves inflating the abdominal cavity with carbon dioxide gas, which creates space for the surgeon to work and improves visibility. It's a delicate procedure that requires precision and care to ensure patient safety and optimal surgical conditions. We typically begin by making a small incision near the umbilicus or belly button. This is where we'll insert the Veress needle, a specialized instrument used to insufflate the abdomen. Before insertion, we lift the abdominal wall to create distance between the needle and the underlying organs. This helps prevent accidental injury to the bowel or other structures. Once the Veress needle is in place, we connect it to the carbon dioxide insufflator. We start with a low flow rate and gradually increase it as we confirm proper placement. There are several safety checks we perform at this stage. We look for free flow of the gas, absence of high pressures, and no signs of subcutaneous emphysema or gas trapped under the skin. These checks help ensure that the needle is correctly positioned in the peritoneal cavity. As the abdomen inflates, we closely monitor the intra-abdominal pressure. The goal is to achieve a pressure between 12 and 15 millimeters of mercury, which provides adequate working space without compromising the patient's cardiovascular or respiratory function. It's important to note that some patients, particularly those with respiratory or cardiac issues, may require lower pressures. Once we've achieved the desired pressure and confirmed proper insufflation, we're ready to move on to the next step, trocar placement. Section 5. Trocar placement, establishing access points. Trocar placement is a crucial step in laparoscopic inguinal hernia repair. These instruments serve as our access points to the abdominal cavity, allowing us to introduce the camera and surgical tools. Proper positioning of the trocars is essential for optimal visualization and ease of instrument manipulation throughout the procedure. We typically use 3 trocars for this operation. The first trocar, usually 10 millimeters in diameter, is placed at the site of the initial incision near the umbilicus. This is where we'll insert the laparoscope, which provides us with a clear view of the abdominal cavity. It's important to insert this trocar carefully, using a twisting motion and maintaining control to prevent injury to underlying structures. The second and third trocars are usually 5 millimeters in diameter and are placed on either side of the abdomen. These are our working ports through which we'll introduce our surgical instruments. The exact placement of these trocars can vary depending on the patient's anatomy and the surgeon's preference. Generally, they're positioned in the right and left lower quadrants, forming a triangular configuration with the camera port. When inserting the lateral trocars, we take care to avoid the inferior epigastric vessels. These blood vessels run vertically along the posterior aspect of the rectus abdominis muscle. Injury to these vessels can cause significant bleeding and complicate the procedure. To avoid this, we often use transillumination, shining a light through the abdominal wall to identify the vessels before making our incisions. Once all trocars are in place, we confirm their position by looking through the laparoscope. We check for any signs of bleeding or injury to internal structures. At this point, we're ready to begin the actual repair of the hernia. The strategic placement of these trocars will allow us to work efficiently and safely as we move through the subsequent steps of the procedure. Section 6. Identifying the hernia, locating the defect. With our access points established, the next crucial step in laparoscopic inguinal hernia repair is identifying the hernia defect. This requires a thorough exploration of the inguinal region and a good understanding of the anatomy. Let's walk through this process step by step. We begin by carefully examining the entire inguinal area using the laparoscope. The camera provides us with a magnified view of the internal structures, allowing us to spot even small defects. We're looking for any abnormal bulging or weakness in the abdominal wall. In many cases, the hernia sac, the portion of peritoneum that has pushed through the abdominal wall, is clearly visible. As we explore, we pay close attention to key anatomical landmarks. The median umbilical ligament, which runs from the umbilicus to the bladder, helps us orient ourselves. Lateral to this, we look for the medial umbilical ligaments, which are the remnants of the fetal umbilical arteries. The inferior epigastric vessels, which we were careful to avoid during trocar placement, also serve as important markers. Identifying the type of hernia is also important at this stage. Indirect inguinal hernias protrude through the internal inguinal ring, lateral to the inferior epigastric vessels. Direct hernias, on the other hand, occur medial to these vessels, in an area known as Hesselbach's triangle. Understanding the type of hernia guides our approach to the repair. Once we've located the hernia defect, we assess its size and characteristics. We look for any adhesions or scarring from previous surgeries. In some cases, we may find bilateral hernias or additional defects that weren't apparent on preoperative imaging. This comprehensive evaluation allows us to plan our repair strategy and ensure we address all issues during the procedure. With the hernia identified and assessed, we're ready to move on to the next step, dissecting the hernia sac. Section 7. Dissecting the hernia sac, separating tissues. Dissecting the hernia sac is a delicate and crucial step in laparoscopic inguinal hernia repair. This process involves carefully separating the hernia sac from surrounding tissues and reducing its contents back into the abdominal cavity. It requires precision and patience to avoid damaging nearby structures and ensure a successful repair. We begin by grasping the peritoneum near the hernia defect with laparoscopic forceps. Using gentle traction, we create a tent-like elevation of the peritoneum. This helps us visualize the planes of dissection and identify any adherent structures. We then use a combination of sharp and blunt dissection techniques to separate the hernia sac from the surrounding tissues. As we dissect, we're constantly aware of important anatomical structures in the area. The vas deferens and testicular vessels in males or the round ligament in females are particularly vulnerable to injury during this step. We take great care to identify and preserve these structures. In some cases, especially with large or long-standing hernias, these structures may be intimately associated with the hernia sac, requiring meticulous dissection. Once we've fully mobilized the hernia sac, we carefully reduce its contents back into the abdominal cavity. This may include omentum, intestine, or other abdominal organs that have protruded through the defect. We inspect the reduced contents to ensure there's no damage or compromise to blood supply. In some cases, particularly with large indirect hernias, we may decide to divide the hernia sac high in the internal ring, leaving the distal portion in place to prevent fluid collections post-operatively. Throughout this process, we maintain a clear view of the surgical field by frequently cleaning the laparoscope lens and adjusting our camera position as needed. Good visibility is crucial for safe and effective dissection. With the hernia sac fully dissected and its contents reduced, we're now ready to move on to the next critical step, mesh placement to reinforce the abdominal wall. Section 8. Mesh placement, reinforcing the abdominal wall. Mesh placement is a cornerstone of modern hernia repair, providing a strong tension-free reinforcement of the abdominal wall. In laparoscopic inguinal hernia repair, proper mesh selection and positioning are crucial for a successful outcome. Let's explore this important step in detail. We begin by selecting the appropriate mesh. There are various types available, including polypropylene, polyester, and composite meshes. The choice depends on factors such as the size of the hernia, the patient's anatomy, and the surgeon's preference. Generally, we aim for a mesh that extends well beyond the borders of the hernia defect, typically by at least 3 to 5 centimeters in all directions. This ensures adequate coverage and reduces the risk of recurrence. Before inserting the mesh, we carefully prepare it outside the body. We often trim the mesh to fit the patient's anatomy, creating a rounded edge to prevent sharp corners that could cause discomfort or erosion. Some surgeons prefer to roll the mesh for easier insertion through the trocar, while others use specialized delivery devices. Regardless of the method, it's crucial to maintain the sterility of the mesh throughout this process. Once we're ready to place the mesh, we insert it through one of the larger trocars, usually the 10mm port. We carefully unfurl the mesh inside the abdominal cavity, positioning it to cover the entire myopectoneal orifice. This area includes not only the site of the current hernia, but also potential sites of future hernias. Proper positioning is key. We want the mesh to lie flat against the abdominal wall without any folds or wrinkles. Securing the mesh is the final step in this process. While some meshes are designed to adhere to tissues without additional fixation, many surgeons prefer to use tacks, staples, or sutures to ensure the mesh stays in place. We typically secure the mesh at several points around its perimeter, being careful to avoid placing fixation devices in areas where they could cause nerve irritation or vascular injury. Once the mesh is securely in place, we perform a final inspection to ensure proper positioning and coverage before moving on to closure. Section 9. Closing up, finishing the procedure. As we approach the final stages of laparoscopic inguinal hernia repair, proper closure is essential for preventing complications and ensuring a good cosmetic outcome. This process involves several steps, each requiring attention to detail and careful technique. Let's walk through the closure process step by step. First, we perform a thorough inspection of the surgical site. We check for any bleeding, making sure all vessels have been properly cauterized. We also look for any damage to surrounding structures that may have occurred during the procedure. This final look allows us to address any issues before we close up, reducing the risk of post-operative complications. Next, we begin the process of removing our instruments and trocars. We do this under direct visualization to ensure no bowel or omentum becomes trapped as we withdraw the trocars. It's important to remove the lateral working ports first, leaving the camera port for last. This allows us to maintain visualization of the abdominal cavity until the very end of the procedure.